Where are you based out of?
I'm out of Pittsburgh, Pennsylvania.
Pittsburgh, huh?
Yeah. I work at the University of Pittsburgh Melanoma Center with Dr. Kirkwood.
Oh, great.
Yeah.
I gave a grand rounds to the derm department, but I did it by Zoom.
Oh, yeah.
I've never been to Pittsburgh. It's supposed to be very pretty with all the bridges and rivers.
It's definitely pretty. It's very cold currently.
Yes. Well, the north.
That'll happen.
Yeah.
All right. So we are ready to roll here in 1 minute. This is always the awkward part where we sit and wait. We'll get it
That's
going.
fine. It's fine. So is this mostly to patients or doctors
It'll
or?
be mostly patient centered. Yeah.
Okay,
Yeah.
great.
So you'll see from my questions, they're pretty basic, but we'll
Okay.
be, yeah. All right. So we're going to go ahead and get started. Good afternoon, everyone, or I guess it's morning on the West Coast. But my name is Melissa Wilson. I am the host of From the Clinic to the Living Room. I'm a physician assistant that also helps out AIM. My guest today for a really important topic about pregnancy and melanoma is Dr. Jane Grant-Kels. Dr. Jane, as her patients like to call her, is a renowned expert in dermatology and cutaneous oncology. She's a professor of dermatology, pathology, and pediatrics. She also serves as vice chair of the Department of Dermatology and director of the Cutaneous Oncology Center and Melanoma Center program at the University of Connecticut. So I am so thankful that you came on today to help us discuss this really important topic. I know in my oncology practice, we get a ton of questions surrounding pregnancy. So this is going to be something that's going to not only help the patients, but help me to explain them as well. So welcome. Thank you for
Thank
joining us.
you.
So I guess we just want to start out kind of easy because, at least in the medical community, it's really well known that, there's a lot of pigmentation changes in pregnancy. We see that quite a bit. So I guess my first opening question to you is it normal for moles or nevi to change during pregnancy as well with those changes that are occurring in the hormones?
No, actually, nevi shouldn't change during pregnancy. There is some darkening, you get darkening of the nipples and a line on your abdomen called linea nigra when you're pregnant, and that's very normal. But moles shouldn't change, except those on the breast and on the abdomen are going to get bigger because the skin is going to get stretched. But if
Sure.
a mole is becoming asymmetrical or changing in any way that's peculiar, you should immediately see a dermatologist and have it looked at carefully, just to make sure it's not a melanoma. And if it is a lesion that's worrisome, you should allow the dermatologist to biopsy it. It's very safe. It's been very clearly shown that a small amount of xylocaine with epi is not going to hurt you or the baby, and you should have it biopsied. But having said that, there's no indication that moles change more frequently during pregnancy, um, or that melanoma arises more frequently in pregnancy. But there was an old theory that moles physiologically can change, and that's okay. It's not okay. If a mole is
Right.
changing, and it's worrisome, you should be treated like everybody else and have it looked at.
Yeah, so those increase in hormones and the changes of the other parts of your skin that change don't necessarily affect the nevi that have already been
The
established.
only thing that you'll notice is obviously as your breasts expand and your abdomen expands, then the pigmented lesions in those areas are going to get bigger because the skin is stretched, and
Sure.
that's perfect. But it's going to do so symmetrically. It's not going to do it in a funky way. So that's
And not
okay.
overnight, like you're
Not
not going to see
overnight,
something
right?
like
But
change
it'll
drastically.
change gradually as you grow.
Yeah, so you kind of answered my next question of what should you do if a nevus changes. We're just going to treat this exactly like we would if you were a regular non-pregnant patient and something is different.
Correct.
I guess one of the, you sort of addressed it in your answer to the first question about, the risks of removal. And, we'll talk about that maybe a little tiny bit later. But I guess, you mentioned that it's very safe to have biopsies taken during pregnancy. I guess the next step to that is like, let's say that you are established that you have a melanoma, if a sentinel node then is asked of the patient in particular, is that something that you would consider to be safe during pregnancy?
So generally, so that's very controversial. I think it is safe. It has been done. You try, if possible, to avoid the first trimester. If you're going to need general anesthesia, we would prefer it be during the second trimester for the baby's sake. But the mother's life comes first, and if it's demanded, it can be done. There are some people who advocate not doing it till after the delivery, but I wouldn't suggest that unless we were close to the delivery and then postponing it just a few weeks. So, again, any general anesthesia would best be postponed for during the first trimester if possible.
Okay. So sorry for kind of jumping us off track. We'll go back a little bit. So you mentioned, obviously any type of change in a mold. Do you increase the frequency at all of the amount of times you see a patient, possibly in the dermatologic setting?
So not for an average patient with no personal or family history of melanoma.
Obvious. Yeah.
Right. If somebody has a personal history of melanoma or a very strong family history of melanoma, has more nevi than the usual standard adult of their age, or has atypical nevi, history of then I try to see them every trimester. And the
Okay.
reason I do is not because I'm worried that they're at increased risk of melanoma. If they're going to get a melanoma, I want to pick it up early. And obstetricians don't generally look at the skin, nor do they don't know how to use a dermatoscope.
Right.
Dermatologists do, and many of them still believe it's okay for nevi to change. It's physiologic, and that's not true. That's been shown not to be true. So I just like to follow those patients every trimester, but otherwise, no, I don't see patients. I mean, that would be hard on the healthcare system for every pregnant woman to be seen every trimester, and
For
I don't think it's necessary. But women should be aware of their own skin and know that if they have a changing mold, they should get it checked out.
Absolutely. So, in the same regard, let's say that a patient has had a melanoma, maybe even has an advanced stage melanoma, stage three, possibly stage four. What advice are you giving to those patients, that are seeking pregnancy?
So generally, we recommend for so somebody with a thin melanoma,
Yeah.
go for it. You
Yeah.
can, I'm not worried, do it. But somebody with a very high risk melanoma, we tend to recommend that they postpone. It's a very difficult question because it depends on the patient's age.
Sure.
So if I tell a 38-year-old that she has to wait 2 to 3 years to get pregnant again, I might be telling her she can't have another child or she can't have a child. So you have to take each case individually. But
Okay.
generally, with high risk melanomas, we ask people to wait about 2 years because it's during the first 2 to 3 years that if something bad is going to happen, it's going to happen then. That's the most intense time. Now, you and I both know that when you have had a melanoma, you're sort of never done with it, that there can be delayed recurrences or even metastases. I mean, I've seen it beyond 10 years, it happens.
Right.
But the most common time that you're at risk is the first 2 to 3 years. And what we want is that if someone gets pregnant, that baby has a mother.
Right.
So, right. And we also melanoma is the most common cancer to metastasize to the placenta and to even cross the placenta and metastasize to the fetus. Very rare, but it is the most common cancer that does that. And so we don't want to put the baby at risk either. So we ask women to wait generally at least 2 years if they're metastatic or very high risk.
Which I think, to be honest, is is actually really good news, because I will tell you that a lot of patients come in that maybe have are stage 3, absolutely stage 4, that are like, I still wanted to have a family, and here I am, is that possible? And no matter how much reassurance we give them, it seems like there's not a ton of literature that we can refer patients to kind of give them that added confidence that this is safe, you're going to be okay, like we can figure this out. And so I think that's where a lot of the anxiety comes from a patient perspective.
Well, as
uh,
people quote, um, it's pretty common that, melanoma that arises in women does so during their period where they're fertile,
sure.
right? So this obviously it becomes an issue. And as women postpone having children because of careers or whatever, or delayed getting married, this becomes a big issue for women. So obviously, it's important. So you have to take the person's age and their family wishes into consideration. And then when they do deliver, I always make sure that the placenta gets, because most placentas get weighed, looked at grossly, and thrown away.
Mhm.
In this case, I want to make sure it's looked at and looked at histologically, many slices, and just to make sure that nothing has presented itself in the placenta. Because then you need to worry about the child if that happens.
Sure. So in the event that something like that would happen, like you would see melanoma cells within the tissues of the placenta, what
Yes.
what does that mean as far as screening for the baby? Like what would you, a
Yeah.
skin exam or?
No, you would have to
Yeah.
do probably more just to make
Yeah.
sure, because unfortunately it's been very, very, very rare. But there have been occurrences where children are born with metastatic melanoma from their mother. So it's very rare. I don't want people to,
No, right.
but you want the child examined to make sure there's nothing going on internally. So,
Absolutely. Yeah, that's what my oncologist, there was one case that happened right before I started working for him, and I, of course, was pregnant within the first year of working there, and was like, so how often does that happen? And he's like, you have a better chance of getting struck by lightning in this building than it happening to even somebody that had melanoma metastatic, so not to worry.
yeah.
So does a melanoma behave differently during pregnancy? That's another like kind of myth, or
Right. It's a
misnomer that we
very
have.
common myth. And, it's, you can understand why people have that
Mhm.
thought, because obviously when we're pregnant, we're immunosuppressed. Otherwise, we wouldn't hold the pregnancy because it's half the dad's
Right.
body, right? So, and we know that when we're pregnant, we make lymphatics and blood vessels better. We have angiogenesis, and lymphangiogenesis is enhanced, and we're immunosuppressed, and we have dark, so there are reasons why people think that, but it has never been clearly shown in very good studies that are with controls. Women who are pregnant who have melanoma versus women who are pregnant who don't have melanoma, they do exactly the same. In
Right.
fact, anything, there's sort of a pregnancy protection. So that if you're pregnant and you develop a melanoma, your chances of it metastasizing or doing worse have never been unequivocally shown to be any different than a non-pregnant woman. And
Sure.
if you have a thin melanoma, they just cut it out and you're done. And
Yeah.
don't worry about it.
That's really, really good advice. And again, like I said, there are so many myths out there that I feel like we could spend 2 or 3 hours going through the big list of questions that we get every day. So I appreciate you taking the time to kind of help our poor little women out there feel a lot better in terms of this pregnancy related question. So I guess one of the other myths that I've had, or questions that I've had as well, is does pregnancy after a melanoma impact your risk of recurrence? I think we've, pretty much driven this fact home that the answer is no, but let's
There's
talk
no
about that.
there's no evidence that that in fact is the case. The other thing is the women come in, can I take hormone replacement? Can I take birth control? The answer is yes. In Europe, the hormone replacement is different and the birth controls are a little bit different than they are in this country. So, but in this country, yes, you can take, there's been no evidence that women who have had a melanoma, who go on the birth control or who get older and want hormone replacement are at any increased risk. So they can go about their lives as best they can, having had that diagnosis, but they can go about their lives in a very normal way.
Okay, so I think that the only other really like pressing thing that I want to address is what happens when you have stage four, say you're pregnant, you get diagnosed with stage four disease. Obviously, if you are late in your third trimester or you're in your third trimester, maybe we can wait until the baby is born to go ahead and start directed immunotherapy or targeted therapy. What are the thoughts surrounding treatment during pregnancy? I know that that's super controversial
No, well,
topic,
it's
but
there prior to 2011, when all we had were chemo,
right,
women were treated with it and did as well as the other women. And the babies, some of them were delivered early, so they were small for size, but most did okay. The new targeted treatments um, are there's concern about them being teratogenic.
sure.
So you can't treat a pregnant woman with that. So you have to, I would get the surgery that I would do, especially if you could avoid the first trimester, that would be best. But if you're second or third trimester, have the surgery and get the tumor out. But you can't start the new treatments until the baby is born, and you can't breastfeed.
Okay.
So you have to not do that while you're getting this medication. In regards to workup, you can get most, ultrasound, you can get chest X-rays with shielding, MRI, yeah, and CAT scans. We try to avoid the dye, and again, the MRI we try to avoid the first trimester, mostly because people have bad reactions to the dye. And
Okay.
but we also the MRI, we're not sure about the heat and how it impacts the baby, so we wait till the second trimester. But
Okay.
so the workup can get started. The surgery, again, general anesthesia, I would try to postpone until you're further along. But you can't, unfortunately, get the new targeted treatments until you after birth.
So when you say targeted treatments, obviously, like my brain thinks of like the BRAF MEK
Right,
inhibitors.
right,
Does
right.
that also apply to like the immuno checkpoint inhibitors like
All
PD,
of those.
all of
Yeah.
them? Okay.
Mhm.
Okay.
There's a concern that they're teratogenic, so you can't take those while you're pregnant.
Okay.
In
And
the olden days, when I mean, interferon and chemo were done,
sure.
and but they don't work as well, and they
Right.
make women quite sick. So obviously, the targeted treatments are the goal.
So I guess the biggest take home message in this entire webinar is really to encourage women to get regular skin exams just like they would pregnant or not. To know that there's no actual equivocal evidence that proves that melanoma gets worse during pregnancy or that it would enhance metastasis or that it wouldn't be safe for a woman to go forward with especially excision during pregnancy. So what I'm hearing, and I hope everyone else is hearing, is that pregnancy is not something that is, I don't want to say a death sentence, but a death sentence with melanoma, and that certainly you can have a family and you can continue to build your family even if you have or have had a melanoma.
Absolutely. And the other really important takeaway message is that I don't want anybody to think that, oh, this mole is changing color and becoming asymmetrical, and that's okay because I'm pregnant. That's not okay.
Sure.
Just because you're pregnant, you don't get, moles shouldn't change except get bigger on the breast and over the where the abdomen is growing. In those states, they're going to get bigger, obviously, but they shouldn't change in shape or coloration. And if they are changing, you should see your dermatologist like anybody else. Don't postpone that because doesn't mean, melanoma is not an unheard of thing during pregnancy. It's not increased. There's no increased risk, but just because you're pregnant, that doesn't give you safety. So
Right. Or
you want if it, God forbid, you get a melanoma, you want it diagnosed as early as possible, where just an excision can cure you.
yeah, absolutely. So get very, very good care during your pregnancy, just like you should when you're not pregnant.
Right,
Really.
exactly, exactly.
So we do have a question on the chat essentially. Someone had just asked, what does very high risk mean? You know, for me, that would be anybody that has maybe a melanoma that has metastasized to a lymph node or obviously has spread to other organs, you know, the lung, the liver, brain, things like that.
Well, also, what I consider high risk is if your primary tumor was ulcerated,
Correct.
if there are, if it's very deep, those put you at risk for the staging that you suggested.
Yeah.
But
So we would be like stage 2BC, all the stage threes, and stage four would be, at least in our oncology practice here, what we would consider high risk.
correct.
Okay. And then we have another little more complicated question about the, you know, testing post, um, like a baby that is born to a woman who has positive placental involvement at birth. So basically, the question says, what testing or screening would you recommend for an infant with positive placental involvement at birth?
So it would have to be done in concert with pediatricians and pediatric oncologists. You don't want to have to put the child through general anesthesia, obviously for a CAT scan or an MRI, but you might want a full physical exam by the pediatrician, feeling for enlarged lymph nodes, some blood studies, and then when they get a little older, possibly a chest X-ray and ultrasound, just to make sure nothing was going on. But there you have to be concerned. I mean, if there's any like a seizure or anything that tips you off that you worry about a brain metastases or a liver metastases, and that has unfortunately extremely rarely, but it has happened.
Now, I wonder, and this is something kind of off the cuff, but I wonder if like the um, newer like ctDNA testing could be something that could be utilized in this kind of situation using like the mother's melanoma as the probe and running the baby's blood through it. I wonder if that would be something that could be interesting to
Um,
see.
That'd be a great study.
I know, right? Maybe I'm worth of new research, but that would be interesting to see if that would pick up anything there. I don't know. We have another quick question. There's a patient that woman that types in, I've had an invasive but contained melanoma with negative margins and all negative genetics. Is there anything else besides like they're doing screening with LDH? Is that helpful? Is there anything else that would be worthwhile for screening for her?
So generally, we don't do a lot of laboratory tests, as you know. I mean, we follow patients clinically. You
Correct.
end up being false positives and chasing and aggravating the patient. And so most patients, when they're diagnosed with a very high risk melanoma, may get a CAT or a PET scan as a baseline. But
Sure.
unless symptoms suggest something, we don't tend to get those with any regularity. And we do it in concert with their oncologist. We
Sure.
have I know you do it at Pittsburgh also. We have a collaborative clinic with our oncologist and our dermatologist seeing the patients together. We feel the abdomen, you feel the lymph nodes. I'm not even sure a lot of people follow LDH. It's very controversial. Unfortunately, there's no one test that to date. I mean, hopefully there will be in the future a
Yeah, well,
blood test.
that would be
Yeah,
nice.
yeah, that would be great.
Yeah, I mean, I think you're right. Like, it's a at least from an oncology standpoint, it's a combination of things that we do in terms of screening, which again, most of that is driven by patient symptoms as well. Like, there's not one special thing that everyone does across the board. Um, I guess our let's see. So there's another woman that said, just to recap, did you say hormonal birth control does not increase your risk of developing melanoma? This person, I guess, has an IUD hormonal based birth control called Mirena. They had a 1A melanoma about a year after the IUD was placed. I guess they're sounding like, are they curious? Was this coincidental, or or
No,
not.
no, I don't. I think it's coincidental. I don't think you can blame it on the IUD. There was one study to show that if you're on birth control for over 20 years, you had a slight increased risk. But by 20 years, usually you're in menopause. So, I mean, depending upon when you start the birth control. I mean, if you're 15 when you start it, maybe not.
Yeah,
But
right.
yeah.
Goodness. I mean, a lot of the other questions that we seem to be getting all kind of are reiterating the same things that we've already asked, whether or not melanoma grows faster in pregnancy because of blood supply and,
No,
whether,
theoretically you would think it might, but there
yeah,
has been no evidence to show that in reality that is what happens. So if you, God forbid, are pregnant and you get a melanoma, your prognosis is the same as anybody else.
that's very good information. Some of the other comments were, as a stage 1B melanoma, should I still wait the 2 years to get pregnant?
It depends upon how old you are, but my inclination would be no.
Sure. So I guess let me see if we have two chats going at the same time. I'm trying to keep track of both of them. I apologize for going back and forth. Here's an actual happy thing. So there's a woman who posted that in 2023 she was diagnosed with stage 4 melanoma when she was 21 weeks pregnant. They made the decision to continue the pregnancy. They actually started Ipi-Nivo at 28 weeks. The baby did 2 rounds of immunotherapy while in utero and was delivered at 34 weeks, and she's healthy and a thriving 13-month-old person. So that's
That's
a really good thing.
yeah, that's a good thing to end on.
Great. It's a really good happy ending. That's what I was
Yeah.
like, wow, this is
Well,
a good.
congratulations, and that's great. I'm thrilled for that lady.
Yeah. So I guess so in summary, we should be getting regular skin exams just like we would pregnant or non-pregnant. It's safe to take hormonal birth control, to do hormone replacement therapy, to have a pregnancy after we've had melanoma. Obviously, these conversations need to happen in conjunction with the healthcare team because it's something that is individual in certain situations for patients in terms of timing. But it sounds like to me that we should just keep having babies and moving
Well,
on.
well, if you can afford them and you want them, absolutely. Again, if you have a very high risk lesion, you'd want to wait a couple of years, and you'd want when you give birth to have your placenta examined.
Correct.
But other than that, if you have a thin melanoma that all they needed to do was an excision, you don't need to postpone. And if you have a mole that's changing, please don't delay. Go and have it checked.
Yeah. I think that's probably of all the things, one of the most important things to take home because we don't take care of ourselves and we need to remember to do that.
And obstetricians who are wonderful, and for many women, their primary care doc during when they're young, are not looking at the skin most of them, I should not all of
Sure.
most of them are not looking at the skin, and they don't know how to use a dermatoscope, which is a tool that dermatologists use, and they're not that, I mean, I can't, well, if I had to, I could deliver a baby, but I wouldn't want to deliver a baby, and or do open heart surgery. They don't know
Sure.
dermatology, right?
Sure.
Right. And so if you have a mole that's changing, even if the oncologist or I'm sorry, the obstetrician is not worried, if you and your spouse, your partner are concerned that it's changing and looks a little, get it checked by a dermatologist. That
Absolutely.
would be
I
my
mean,
advice.
and that's good advice for the general public. I mean, I've done melanoma now for 20 years and I truly cannot tell you how many adult people have never been to a dermatologist in their whole entire life. So, that in general is amazing advice. We should be having our skin checked by a professional at least once a year. So,
I would agree. I would agree, especially if you've had a lot of sun damage or been to tanning parlors, gotten sunburns, or have any family history of skin cancer. You should get your skin checked.
absolutely. Well, listen, Dr. Jane, it was an absolute pleasure speaking with you this afternoon. I appreciate you taking the time in the middle of the day out here on the East Coast to spend time with me. And I hope that if we get any additional questions, I'm happy to answer them through the Ask an Expert line. I can get them to you, for
Absolutely.
your expert opinion. And I So very much appreciate you, and I hope you have a wonderful
Thank
day.
you. Thank you for asking me to join you. Take
Absolutely.